welcome to another episode of Surgeons' Lives. I'm your host, John Monson. Today's guest is nothing short of a legend in the world of surgery. Dr. Barry Salky was at the very forefront of laparoscopic surgery, not just colorectal surgery, but also general surgery. But he's perhaps best known for being a giant in the arena of inflammatory bowel disease during his career, a stellar career in Mount Sinai in New York. But there's a lot more to Barry than meets the surgical eye, because he's a gourmet, an enormous wine enthusiast, and an international traveler. So it's going to be a real treat to hear his story and tell us some tales about his life. I'm John Monson, and this is Surgeons' Lives.
How you doing?
I'm good, thank you, Barry, and thanks for taking some time today to talk to me for what I hope will be just a relaxing hour or so. Our podcast called Surgeons' Lives is, as it says it is, it's about surgeons' lives, but not so much. I mean, obviously, we'll spend some time talking about the fame and fortune derived from being a wonderful surgeon, but as much as anything else, it's the other bits, which is why I have referred to it as, Surgeon's Life, but the stuff that matters,
Sure. Well, this is what I'm looking at right now, so it always makes me feel pretty good.
Yeah. So you're coming to us, beaming to us today from Colorado, is that right?
Snowmass Village, Colorado. It's part of Aspen.
Yeah, yes. Um,
It's a wonderful place.
so let's start in the way that I try and start these by asking the lucky winner to talk to us about a little bit of a brief summary of your early life and career, which I always ask people to start with the words "I was born in."
Yeah, well, I was born in Memphis, Tennessee. Basically a southern-born boy, born and raised in Memphis. And really, I didn't get out of the South until I went to college, which is went to the University of Illinois. It's actually kind of a funny story of how I got to the University of Illinois. Um, my parents were not born in the U.S., so I'm a first generation American. And when I went to high school, getting ready to graduate high school, they really had no idea of where I should go, or where I had no idea where I should go to college, and they were a little help with that. So they took me to an educational tester, and I took all these tests, and the guy tells my parents that I am born to be a chemical engineer.
Okay.
So with that armament, I went to I looked around the colleges sometime within a 500-mile radius of Memphis, and University of Illinois popped up, which was a fantastic engineering school. And lo and behold, I got into the chemical engineering department as a freshman. I was out of it my second semester. It was totally not for me. That is for sure. And then I just sort of banged around in college until my junior year. I really didn't have no clue about what I really wanted to do. And a couple of my friends in college sort of suggested, almost on a lark, since I took a lot of science courses, that maybe I should try pre-med. And at 20 years old, to say that I was suggestible is an understatement. And I said, sure, why not? So I started taking some pre-med courses, and lo and behold, I did okay in that, and kind of liked it. And when it came to graduation, it took me an extra semester to graduate because I needed some extra courses. I went to University of Tennessee Medical School, and I'm from, like I said, from Memphis to begin with, and got in as an in-state student, and the rest is kind of history of being a doctor. The surgical story is another story, but
Sure.
that's how it became
And where did your parents come from?
Poland.
Poland. Yeah.
My mother was really an American. She got here when she was I think around 2 years old, maybe a little bit less, to Shreveport, Louisiana. That's where her family ended up. But she was in essence an American with a Southern accent and all. My father did not get to the U.S. until his late 20s, and that's via 7 years in Cuba, because at the time this was back in the just after World War One,
Right.
and they could not get in. He could not get into the U.S. then,
Right.
but eventually did, and so that's where they came from originally.
Yeah. Yeah. And so you did your medical school in Tennessee.
University of Tennessee Medical School. That's in Memphis. The medical units are in Memphis. I think
Yeah.
they do have a branch now in Eastern Tennessee in Knoxville area, but yeah, it's Memphis.
And
Funny
so,
thing was, I was just there a weekend and a half ago for a family wedding, so kind of went by and saw what's happened to it. It is still there, but it is expanded quite a bit.
and you're one of many, or only child, or somewhere in
Oh,
between.
sorry. I have an older sister, 8 years
Mhm.
older, an
Mhm.
older brother, who's 2 years, 8 months older, and me. I am the baby of the family.
Okay. And so,
All the pluses and minuses that go with that, by the way.
sure, sure. So when did surgery first hit your radar?
Um, as a in between the basic sciences and the clinic years at the University of Tennessee, I did sort of an externship between those two things, 3 months worth in Chicago, uh, uh, and um, trying to get the exact timing of that. Went back to Chicago because that's went to University of Illinois and had a lot of friends there, and so I decided to spend 3 months there, and that's where I got exposed to surgery. Um,
Yeah.
I had a first cousin who was chief of staff at the Baptist Memorial Hospital in Memphis. Baptist Memorial System in Memphis is a huge,
Yeah. Yeah.
huge system,
I'm
and
familiar.
he was a cardiologist, and chief of staff there is respected and all that sort of stuff. And I always assumed that I would kind of follow his path, but when I finally got this chance to do surgery as a third year medical student with some supervision, very little supervision, I will say, back in those days, but some supervision. It really just like a switch went on in my brain where I was really good with my hands or decent with my hands, and the thought process was is that here was a problem. You could fix it mechanically most of the time, and most of the time the results would be good, and that was very positive for me, and that's why I got into surgery.
So you didn't have it wasn't as, sometimes people, and particularly nowadays, which I'm sure sometimes they download them, but you often see these personal statements of, a vision appearing in front of the person, that a surgeon appeared, with a glittering halo around them, and the day was saved, and they knew they had to be a surgeon or something. It wasn't quite like that. It was more
I
of
would
an
say for me, I was the antithesis of that.
yeah,
When I say that I really got into medicine on a lark, I'm really not kidding.
yeah,
In college, um, the university, I mean, I was always a decent student, but I really had just, I knew what I didn't want to be. That I
yeah,
knew, which
yeah, yeah.
that I was sure of, but I didn't know exactly what I wanted to be. And so, as it turns out, uh, it was good for me. But I tell you, there was a lot of luck in that.
So where'd you do your residency?
Mount Sinai, New York. That's a whole nother story. So the only thing I knew, first of all, the only thing I knew that I wanted to try a different region. I wanted to get out of the South and see what the rest of the world was like. Um, by the time I was a senior in medical school, and by the way, we were on the quarter system. So University of Tennessee was 3 years, 3 months total school. It wasn't a 4 year program.
Right.
And uh, I met my wife 3 months before we got married. It was a whole deal for 3 months. She's still my wife as of 52 years worth. Once again, totally luck, really. But she had some influence in terms of where we were going to end up because I knew I wanted to end up in a big city. Um, and I applied to several big cities. Uh, and actually, I mean, the truth was is that I was sort of hooked in to Michael Reese in Chicago back in this was in the 70s. So this is different. Michael Reese at that point was a going concern, had a strong research component. The chief of surgery at that time there was a guy by the name of Gerald Peskin, um, really good guy. Um, and that's where he liked me as I spent the 3 months there and was going to offer me a slot in the matching program.
Yeah.
So I knew about it a bit. And then about 2 months before that was all coming down, he called and says, "You better look elsewhere. The building, the hospital system has been sold. The Michael Reese will not be the same as you saw it. You better find another place." So I kind of scrambled, and the other part I liked it very well also was Mount Sinai in New York. And unfortunately, I matched there, and that's where I ended up. But
It was
could have been somewhere else very easily.
pretty decent of him to call you, actually. I mean,
Oh, totally,
you know,
totally. Because it would have really, I would have been there for a year. That would have been it. I'd been
yeah.
out of there.
So Mount Sinai, and did you ever leave?
No, at Mount Sinai.
Yeah.
No, yeah. I was in the Army for 2 years,
Oh, okay. Right.
U.S. Army,
Yes.
with an honorable discharge. But no, I'm one of the few people around who are in academia
Yeah.
who stayed at the same institution. I did my training there. I got an offer when I was in the Army to come back there and finish my training. They had a pyramidal program at the time, so it
Right.
wasn't a guarantee. That totally since changed now, of course.
Yes.
So I got a chance to the chief resident, which I was, and then when I finished the program there, I always assumed that I would go back to Memphis. My
Right.
whole family is there. My
Yep.
wife's family was there. Um, it just never thought that I would stay in another place. Um, and then during my chief residency, I got an offer from a private practice group at Sinai that was just unbelievable. They were academically oriented, but in private practice, it was the best of both worlds. They had a incredibly strong IBD component to their practice. Almost 50% of their surgery was inflammatory bowel disease, which clearly was a very challenging type of surgery.
Yeah.
So I got that offer, and we ended up staying in New York. And I've been in New York ever since. Only at Mount Sinai, but in a variety of different uh, um, positions at Sinai, both
Yeah.
on the voluntary side and on the full-time side.
And at that time, what were you calling yourself to people? Were you calling yourself a general surgeon, an IBD surgeon? What, as we mentioned, it was a different era then for a
When I
start.
when I finished training, I was a general surgeon. Clearly, I had.
Did you have a
Funny
vision? I
story
mean,
also, because the last thing Mount Sinai needed was another general surgeon. There were a lot of them there.
yeah,
There were a lot of good ones there too. There were a
yeah,
significant number of not so good ones, but there were a lot of good ones there. Um, the the group that I joined, that asked me to join, they were all technically terrific surgeons. I mean, I saw them during my residency as I was training,
yeah,
and almost all of us wanted to emulate the type of surgeries that they did because they were
yeah.
they were just super technicians, and always a patient first type things. So it was very very cool to be that, but to be asked, and of course I accepted. But um,
So
that is,
what year is this now?
I graduated in 1978. 78.
I graduated from your residency.
My
Yeah.
residency. I finished my training in 1970. I started in 1971, but I finished in 78 because I had 2 years in the Army from
Yeah.
73 to 75 from the Vietnam War business.
So 79, 80, 81, 82, etc. What were your operations in those days?
So that actually is probably the most important segue into what I did when I was actively operating. So, like I said, the last thing they needed was another general surgeon. So this was in the days where sonography had just begun.
Yeah.
CT scan was not on the horizon, certainly not MR. The only thing they really had for evaluation of liver pathology was a liver spleen scan, which of course was the flow scans, and it really didn't give a lot of information about what was going on. It was either a defect or there was no defect. And because of that, one of the gastroenterologists at Sinai suggested, an older gastroenterologist actually, experienced, said, why don't you learn how to do diagnostic laparoscopy?
Yeah.
We could really use someone who knows what they're doing. And the reason that they said that, because there was a gastroenterologist at Sinai who knew how to do laparoscopy. It was awful. Not only was it technically difficult in getting it in, actually most of the time he did get it in, but his interpretation of what he was looking at was off the wall. So, and the surgeon he had backing him up was one of those guys who had no idea what he was doing. So it was not a good combination, really. It's a true story. I mentioned no names, but that's what it was. So I learned how to do diagnostic laparoscopy from H. Worth Boyce Jr. He's was the chief of GI at the University of South Florida in Tampa. Really good guy. We kind of bonded a lot because he was a lifetime colonel in the Army, and I had done my 2 years in the Army, so kind of liked me to begin with.
Yeah.
And I learned how to do diagnostic laparoscopy under local anesthesia, nitrous oxide as the insufflation gas of choice, low flow insufflators, 1 liter per minute. They didn't have the high flow machines at that point. That's how I learned how to do laparoscopy. And by the time, I'm sure you'll have other questions, but from the time I learned that in 79 until Lap Coley came on the field, I had already done 1,000 diagnostic laparoscopies, including some appendectomies under direct vision, and crazy stuff, drainage of because I was a surgeon. Some pubic abscesses, splenic cysts, things that were more therapeutic, but only with a direct view, no camera attached. We had a teaching scope because I was teaching residents how to do this stuff. So that's how it all started. So that was my expertise when I finished my training was at 1 year was diagnostic laparoscopy.
It's intriguing. Of course, as you know, I'm far, far, far younger than you. But when I was in Leeds,
I will still talk to you. It's okay.
So in 1983, I left Ireland and went to Leeds, and I worked with a general surgeon who did diagnostic laparoscopy under local anesthetic.
Oh, cool. Who was that?
The late and really great Tom Brennan was his name. He was in St. James's in Leeds, and he worked as partners with Jeff Giles, the late Jeff Giles, who was the chair of surgery. But so he taught me how to do local anesthetic, and getting the patient to count 1, 2, and 3 and cough, with the needle and all of that sort of stuff. And we did this mostly for sounds as though we weren't as adventurous as you, but we were doing liver biopsies and biopsies of ascites and stuff like that, etc.
Oh, yeah.
So the key, and I'm guessing you'll probably agree with me that when at the end of that decade, and when video laparoscopy came along, the one thing that I had that you had that other surgeons didn't have was I knew how to put the ports into the patient.
Clearly.
And so, one of the biggest problems that general and other surgeons had at the beginning of video laparoscopy was they didn't know how to put the ports in or insufflate the patient, and there was that caused lots of trouble,
Oh my
as
God.
you recall. So it was very interesting, and the only take home lesson I learned from that is that you most definitely should not do a true cut liver biopsy on a patient laparoscopically and forget to put the local anesthetic in the skin. That definitely is not a good idea. So
Sure.
I did do that once. So he obviously, gastroenterologist, was obviously one of your first mentors. You must have had other mentors throughout your career.
Oh, clearly. Most of them. So what's kind of interesting is that besides the diagnostic um, laparoscopy that I was doing a lot of, um, the other two things I did a lot of were, number one was breast surgery. For
Okay.
some reason, I just ended up doing a lot of that within this practice. And the other part of it was the IBD.
Yeah.
So, and the IBD component, as it turned out, really was a major input for me in terms of how my practice would evolve over the years. And most of those mentors were gastroenterologists
Yeah. Mm.
and well-known gastroenterologists in the field of IBD.
Yes.
Um, everybody would recognize their names, and they were very, very helpful, and they were very promoting of me because of this laparoscopy viewpoint that I had, yeah, it really was unbelievably helpful in terms of how my practice evolved over the years. Between the, of course, there were surgical mentors. My three partners, especially two of them. If I could operate like them, I would be very, very happy. Patients would be very happy because the results were very good.
Yeah.
So, yeah, it's good.
Yeah, did you fall into mentors, or were you intentional about it?
Did
Go
I
out.
fall into what? I'm sorry, I didn't hear.
Did you fall into a mentor relationship with them as a mentee, or were you intentional about seeking out mentors? It's one of the questions that younger surgeons ask now, how do I find a mentor? What do you say to them when they ask you that?
It's really, I never thought about that too much, but it's interesting where I was. So Mount Sinai at that time was almost all voluntary. The full-time system at Sinai at that point,
Hmm.
now it's totally reversed, but at that point was full-time. So to say that the private practice of surgery was competitive in New York City would be a gross understatement. So most of the surgeons, while they were happy to have you assist and do some things on the patients, um, they were not very promoting.
Mm.
And I can say this is true not only at Sinai. I had friends at New York Hospital and at Presbyterian. It was basically the same. It was just the milieu was totally different.
Yeah.
It was a very competitive environment. So most of it would have been really, really hard to ask a specific surgeon to mentor me. Saying that, the fact that I was asked to join this private practice group, I did have that. And it came
Yeah.
with a package.
Yeah. Yeah. Yeah.
And it came with the package in a big way, especially if a very complex case fell into my lap. The first people I went to were my partners. Said, I need some help here. This is,
Yeah. Yeah.
and they were very, very good about doing that. But it wasn't a general mentorship. The gastroenterologists, on the other hand, since I wasn't competition to them,
Yeah.
because we
Yeah.
were not allowed to do flexible endoscopy. Surgeons were at that point in time were not allowed to do that, and we were absolutely zero competition, and they were very forthcoming with helping,
So
promoting.
you tell a story of a truism in human life. People say I love competition, but that usually is somebody who doesn't have any competition who's saying that. But
Mhm.
um, the issue of that competitive nature, which is inevitable in any sort of in an eat what you kill model. Do you think that's a good thing, or I mean, it has some good elements to it, obviously, but and it has changed over the years with the transition to a lot more employed models. But I mean, that competitive market, the late Gore Vidal once said, every time a friend of mine succeeds, a little something inside me dies. Is that a good thing for surgery?
Interesting question. I've always kind of marveled at the fact that we who are training people to do surgery are training our competitors, and
Yeah.
it always, and I've always understood that. Um, and you could actually take that a step further in terms of reimbursements for surgeons. I mean, there's no difference really from an insurance perspective of someone who's just finished his training, who's out
I agree.
25 years, who's got all the experience in the world. And I mean, that's not the real world other than medicine, or
Yeah.
especially other than surgery.
And
So, I
and
mean,
and just one small point, because I've been having this conversation recently. It's not universal in surgery either. For example, plastic surgeons do very much charge what they think they're worth, rather than,
absolutely.
so it's just us dummies in GI surgery that get, the same rate.
Um, so if you'll ask me that question a little bit later, I think I'll have a little contrarian view of what you just said, but because mine was a little bit different how I approached the
Yeah.
practice of surgery, the actual economics of surgery, of which nobody teaches anybody when they're training, which is
No.
that's a big problem, a whole different problem uh,
Yeah.
from our perspective. And I think that's a big mistake that we do. Um, but anyway, um, I forgot what
So
I was.
so when did you you were getting into your stride, if you like. When I first heard of you, and we were both, playing around with advanced laparoscopic procedures and, operations that were nobody really knew what we were doing in terms of who was the ideal case. And, there was the port site metastasis argument and all of that sort of stuff. Was there and at that time there were all sorts of laparoscopic stars suddenly appeared, Eddie Joe Reddick, and people following on from there. You know did you again, were you intentional about that, or just did you wake up one day and suddenly discover, hey, I've been doing this for years, guys. I'm an overnight sensation who's been doing it for a decade. How did that morph for you?
Okay, so yeah, I had a I kind of divided things between the early days diagnostic laparoscopy,
Mhm.
then the early days of therapeutic laparoscopy, and then maybe 5 or 6 years after that when really advanced therapeutic
Yeah.
laparoscopy started to take off. And for me, those were definitely different times.
Yeah.
Um, so let me take the beginning of it. So my transition occurred from 79 to when I did my first lap chole, which was in January of 90.
Yeah. Mhm.
January 90. And um, actually, the funny thing is that I'd always, all the presentations that I made in terms of laparoscopy, diagnostic laparoscopy, were done through the American Society of Gastrointestinal Endoscopy, ASGE, because the surgical societies, all
Mhm.
of which I were members of, including SSAT, had no interest in diagnostic laparoscopy at that time. I mean, none. Many times I tried to get something on, and I was doing some really interesting stuff in the 80s. I was doing retroperitoneal biopsies in the mid 80s laparoscopically and saving people major laparotomies for making diagnosis of lymphoma, which wasn't, and this is things that surgeons really need to know, but they wouldn't accept it. So it was a different time period. When I originally learned how to do the lap chole, which was in late '89 in France, and I came back to start doing it. And once I started doing that, it was very obvious to me after the second, third case that this technology was going to revolutionize surgery. I mean, it was pretty. So I did just fall into laparoscopy, sort of. But once I fell into it, it was clear to me that this was a technology that was going to happen. And some of the stuff in the late 80s, actually, I got approached by Olympus Corporation, but this was, I think it was in, I want to say 87, 88. This was at the time that lithotripsy was trying to make a run at treating gallstones. And we were trying to come up with a way of accessing the gallbladder to block the cystic duct so that you could do lithotripsy and not have the stone fragments go into the bile duct and cause cholangitis. I mean, it was like things that were crazy stuff that we were trying to do. So, the answer to your question basically is just, I sought this. I went looking for it. Once I knew that diagnostic laparoscopy or the technique of laparoscopy really was good. I mean, really good for patients. So that was the first part of it. So that I would put that at around 89, 90 type thing. From 90 to 93, 94, we were, there was a small group of people who were doing lots of this stuff. I mean, I can go through all the names, but you know, I was lucky to be part of that group.
Yeah.
Phillips, Morris Franklin, I mean, Barry McKernan. There were a few of us who were like going crazy with this stuff because we knew what it was going to advance to. We knew that it was going to advance. Exactly how far, none of us had any idea that it was going to do what it did. But that part of it was very, very exciting because every day, or at least maybe 3 or 4 times a week, we would all talk to each other and tell each other what we were doing. You did a necrotic gallbladder? How did you do a necrotic gallbladder? You know that type of thing. There was a Maritzi. What are you talking about? You can't do that. So crazy stuff that we were trying to learn about. So, including back in really in the early '90s when colon stuff started.
Yeah.
So we were all like crazed about what was going to happen. It was clear to me at that point that this was going to revolutionize. How much the revolution we didn't know, but it was going to revolutionize the way people were doing surgery. So,
yeah, it was a big I was laughing at the lithotripsy because around that time my research fellow was a guy called Ara Darzi.
I know it very well.
Yeah. And I went to London and cholecystectomy was a private practice operation and we were in Imperial College, so you didn't have hundreds of gallbladders. So we were looking for something to do because, like you, we realized that this was not going to go away. So we made a bet with 2 guys that we could take all the appendixes out in a year for acute appendicitis. You could do them all laparoscopically. And I vividly remember on a Friday spending about 2 hours trying to find a perforated retrocecal appendix in a young man, and which I eventually did and took out. And I vividly remember saying to Ara, because we used to do them all together. I was a young attending and he was my fellow at that stage. I said, you could take somebody's colon out doing this, because I'd mobilized the whole right colon. And on the following Wednesday, I did I went and took a guy's right colon out, which Ara tells me was the first one in the UK. But the point being, every day was something new they were doing. And, I took a lot of, I think the word would be criticism or critique from the establishment and the colorectal society saying, you should stop this. You shouldn't be doing this. It's not safe. And, I remember saying to them, I've done cases where you can tell instantly. There's no way any open case would ever have recovered like that. That's not the question. The question is, how do you do that result in everyone? Yeah, you got it there, and I vividly remember being in an argument with St. Mark's Hospital, and they said you should stop it because it's not good enough. I said, do you think people said that to Sir Alan Parks when he did the first 3 pouches? They sure as hell didn't go that well, but
So
now it's
I remember like yesterday when I asked my chief of surgery. Well, I told him I was going to go learn how. I was private practice. He was full time, and his name was Arthur Alphys. He since passed away. He was a really good guy and promoted everything once we realized what was going on. But he said, "You can go look, no problem. But if you think you're going to be doing one here anytime in the near future, you are crazy."
yeah.
So I went and looked, and I came back, and I told him, I said, Arthur, this is really something that we have to do. This is really good for patients. So, he eventually came around and did some lab stuff, and then, did the surgery, and it worked fine. So that was one point. But it was the years between when I first started doing gallbladders and some of the advanced stuff. I got to tell you, and I'm sure you'll agree, those were the most exciting times from a surgical perspective that you could ever imagine. Because, I mean, it was just so crystal clear that all this stuff, even with the pushback from academia, and even with the pushback in port site metastases, all the things that clearly had to be sorted out. But there was no question that this was all going to happen because it was so good for patients.
Yeah, and I have a slide that I show the 3 phases of minimally invasive surgery operations. The first one is that can't be done. The second is that shouldn't be done. And the third is I can do that. And the truth, what I often say to people, there was a phase you remember where people said, no, I don't want my operation done laparoscopically because it was a lot of media about danger and stuff like that. And there were patients saying, I absolutely do want it. But what I always say to people, I've never in my life had a patient say to me, could I have a really, really big incision, please? That's what I want. Nobody says that.
No, the only people who said that were the surgeons who
Yes.
didn't do laparoscopic surgery, who said that there is only one way you can get this done, and that's through an incision. You're crazy if you go have it done laparoscopic. A lot of that too.
So I described in my little introduction to this, which you'll only hear when it goes out, but not very lengthy, but I described you as an international traveler and something of a bon viveur.
Moi, je parle français, so je comprends.
So tell me that story. How did that come about? I mean, there you were busting your guts in Mount Sinai, making a living and doing very well. And had you always been a traveler or what? Mm-hmm.
No. It happened because of laparoscopic surgery, clearly. And the initial entree into that came from gastroenterologists,
right,
not from surgeon. Mm-hmm. So there was a very well-known Jerry Way. I'm sure you know. Mm-hmm. So he's a very good gastroenterologist in private practice at Sinai, but had an international reputation, was going all over the place, doing all these innovative stuff in terms of colonoscopy because he was one of the originators of colonoscopy. Yeah. So he had a good friend in Chile, and a gastroenterologist, and he was friendly with some of the surgeons at the university there in the private practice thing, and he asked Jerry Way, who could come down and teach the surgeons how to do laparoscopic surgery, and gallbladders, and actually it was just gallbladders. And now that I think about it, and he gave them my name. So that was my first invitation. That was in 1990. And that really opened my eyes to the fact that number one, There are a lot of talented surgeons out there, and
Yeah.
they're not only in the US. That was number one. Number two, there are different viewpoints of how to approach patients. And more importantly to me, because speaking of the bon vivant, was that there are a lot of different ways that your life can be lived that can
Yeah.
be cooperative, that can be productive, and it's a different viewpoint than you have in the US. And that was really, really important to me. And it opened my eyes. And so that got, so once that started, there were other invitations that came from different places. India was one of the early ones, which is why I've been there 20 times. And France as well, because when I learned how to do this from Jacques Perissat,
Yeah.
uh, and oh my God, what's what I have in my brain? Who's the guy in Paris? Uh, Wonderful surgeon who did lap co. I just can't think of his name right.
Yeah. Who was in Hotel Deux? Um, um,
It will come to me because
yeah.
he was another one of the mentors who taught me how to do lap chole. Um, uh, I had a deep connection to France,
Yeah.
and so a lot of that happened from there. And then, of course, the companies got involved in my association. Not to mention, well, then my association was with Ethicon, not with U.S. Surgical. There are a lot of reasons for that, which I cannot go into. But uh, that's how the international stuff happened. So lucky me, very lucky me, I got to see how other people lived, other cultures. Um, it really made me understand maybe I should have some political leanings because there are a lot of different ways to skin a cat.
Yeah.
Uh, Unbelievably important to me. And to this day, I will say, um, it affects the way that I think. It affects my relationship with not only my colleagues here in the U.S. but also abroad, and it's very very important. A lot of the U.S. surgeons, a lot of the U.S. people in general, but
Mm.
especially U.S. Surgeons, uh, live in a bubble, and they don't
Yeah.
realize that there are
Mm.
other ways, and there are other people, and there are other ideas, and it's very very. It was really great for my practice of surgery. It made me a much better surgeon.
It's to me as an immigrant, it's always been strange to me that Americans who think nothing of spending, going on a road trip of 10, 20, 30 hours, are aghast at the possibility of going somewhere called not America. And it's not a good thing. I mean, they're not good travelers internationally, and the trainees traditionally, of course, they've never had to because it's a big country and you can achieve most things. Somewhere you'll find somewhere that's a place that offers you the best of this and the best of that. So you don't really, if you come from Ireland, it's a pretty small country. You got to leave. Everybody was known to Irish trainees had to do BTA, been to America, and BTE, been to England. Because it's just a small country, you can't train there. And I do think you're right. I mean, you learn. The world is very different to what you think it is, and the only way to find that out is to get out and see it. And of course, some of it's as bad as you see in America.
Oh,
You know,
well, there's all kinds of surgery, as you know well.
yeah, and very
So,
much so.
but I think back in the 90s, 2000, um, it wasn't so common. I think nowadays it's changed a fair
Yeah.
amount. That there's a lot of cross pollination for sure. I don't think there can ever be too much cross pollination. Honestly, I really don't.
No, it's interesting. Back in the 90s, as you say, traveling was. Certainly being there was, but traveling was almost enjoyable. It's the actual process of traveling now is not enjoyable, and it's not just down to COVID. I mean, it's it's just become less enjoyable.
Really.
And of course, what COVID has done is produced all these hybrid things. And I mean, they're great if I want to interview Barry Salky, who's in Colorado, but not really if you want to interact with people. I mean, it's not the same at all. So your interest in gastronomy, food and wine, have you always been a foodie or a wine enthusiast?
No, no, but I did grow into it, and once I did grow into it, I grew into it pretty well, I think. um, the food business was because my wife is a terrific cook,
Right. Okay.
so that was the start of it.
Hmm.
But the traveling was really
Yes.
keyed me into the food. I mean, that was a part we don't really talk about too much. We talk about teaching surgery, somebody teaching me what to do, what not to do. We saw all that stuff on international travel, but a lot of it, we were entertained. Uh,
Yeah. Yeah. Yeah.
and when I say we, I was also very, very lucky that my wife traveled with me. She almost never stayed home. And that was, we've met, and become friends with people all over the world because of that. But a lot of that, after you did your work, had to do with the food and wine. And I was a sponge, and I
Yeah.
really, really enjoyed it. And to this day, I still do.
Yeah, and if you have the good fortune, of course, to bump into people like George Fielding, you cannot emerge from that experience without an even greater passion for wine, for example, and food. And he is naturally one of the surgeons who appears on Surgeons' Lives.
He's totally passionate about food and wine as he was with surgery. Totally passionate. It's great.
Yeah.
A lot of people, some people, especially in America, thought it was really kind of pretentious to go crazy over things like that. But it's an for me and my wife and my children, by the way. Now, it's one of the essential pleasures. I mean, they work
Yeah.
hard, but afterwards, there's no reason why you can't enjoy the fruits of your labor.
Sure.
Like one of
Sure.
those things, besides family, would be food and wine.
So, would you describe yourself as retired?
Retired.
Yes.
I'm retired from the clinical practice of surgery. I'm not operating on anybody anymore.
Okay.
Not retired, that is for sure. I'm trying to develop a device, a surgical device. I have a business partner, and we consult for several startups, trying to get them going. And yeah, we're busy with that.
Good. Yeah.
It's
How did you decide to stop operating? I've a number of I've interviewed a whole bunch of people for this, obviously, and several people have said that mostly people of a more senior nature, have said that they're intrigued by the suggestion that surgeons after an age, whatever that age might be, 60, for example, should undergo voluntary cognitive and motor testing, non-punitive. What's your thinking on that?
I think that's a little BS, to be honest with you. Um, for me, I know everybody's a little bit different, but for me, I mean, I retired from the active practice of surgery when I was 73. Um, I thought, let me take it back a step. I had several independent people. I asked not only the chief of surgery, he had to do it as his job, but I
Yeah.
had other people watching me to make sure that I wasn't doing crazy things and that my results were still as good as they ever
Yeah.
were. And I think that's an important part of knowing when it's time to stop, because you actually, I don't think, know when it's time to stop from a technical perspective. It, unless there's some disaster out of the blue, but
Were
you don't.
you were you were you more interested or worried or concerned about doing crazy things or just doing what you used to do but doing it badly?
Combination.
Yeah.
I mean, for me, from the beginning, it was all about patient care.
Mhm.
Uh, I mean, my results were good. I had low complication rates, I had low infection rates, uh, and it was very, very important to me that that type of thing continue. The other thing was is that I had seen people being asked, I shouldn't say asked, being told that they have to stop. That
Mhm.
was not going to happen to me. That's one of the
Yeah.
reasons I put a couple of people to watch me. Um, I gave up being chief of the division of laparoscopic surgery at Sinai in '09. So I stayed on after that, but purely as just on the clinical aspects. I
Yeah.
tried my damnedest not to interfere with the chief of laparoscopic surgery uh, that replaced me. I mean, the last thing I would want is someone to be looking over my back and telling me what to do. So I tried this. I did stay out of the administrative arm of the Department of Surgery and just to do surgery. So, which gets back a little bit in terms of why did I stop? A little bit about the economics of surgery. Um, it's really kind of interesting. When I was out 2 years at Sinai, this
Right.
was at the beginning of managed care. And there was a man, I'm not going to mention the name. Yeah, that's probably not a good idea. There was a managed care company that made a presentation to Sinai that they were going to increase our patient load by somewhere between 25 and 30%. Uh, you were going to be busy as you can be. The only thing you had to do was to uh, take as payment in full what they were going to offer, and
Yeah.
they were going to offer a little bit less. I think it was around 10, 50% less than the
Yeah.
standard fees that were out there. I'm not even sure it may have been based on Medicare at the time, but Medicare at
Yeah.
that time was decent, a long time ago. Um, and so I had a simple question. I don't even remember what the question was because it's not important now. Uh, But the CEO was inundated by questions, and at the end, I found him and I said, "Excuse me, I want to ask you a question." He turned me, he was like crazed for something. He turned around to me and he said to my face, "Doctor, I don't care if you join this or not. This is going to happen. We don't really care about you. We only care about what's going to happen in terms of medical care and how that's going to be progressed." And I looked at him like he was crazy. But from that point on, it was pretty clear to me that insurance companies are not on doctor sides.
No, no, no.
And I mean, it was a firsthand experience. And since that time, I never participated with an insurance company from the beginning.
So, in that category of I don't take insurance.
Correct.
Yeah.
So I had, and as things evolved, I had my fees, which I
Yeah.
thought were what the fees should be,
Yeah.
and that's what I charged. And I didn't accept. Some of the insurance companies were great and they paid it, fine, but others were lousy.
Yeah.
So
Yeah.
patients had to pay the difference, or I negotiated with them in some way, manner, shape, or fashion. But I never
So that's
participated.
I mean, I'm sure it's not exclusively so, but it's a heavily New York thing that um, it's not widely replicated
I
around
know,
the country, and so that's great. You were able to do that.
I think there's. I personally think there are some reasons for that,
Yeah,
and a lot of those reasons that were sort of out of the control of the physician. Um, Physicians have been told, and it also has to do with the economics of how hospitals get paid and more full-time people versus
yeah,
uh,
yeah.
people who were full-time in the institution and other ones who are in private practice. So it makes a difference, but it's not dissimilar from hearing news over and over. And once you hear it over and over and over again, you begin to believe what you're being told.
Yeah,
And
yeah.
physicians are being told that this is the way you have to do it. And that's participating with insurance companies. Uh,
Yeah.
or, you know,
Once it was agreed that insurance companies were allowed to be for profit, I think that was an enormously retrograde step, and it's never been in the interest of the patients or the doctors. Um,
Totally.
that's a problem. If when you're in a system where the payers don't care about either the recipient or the deliverer of the care, it's a bit of an issue.
It's a problem. So that was part of the issue. Um, and even though I mean I was still operating when I was at 73, but it just something in my brain said, you know what, it's time. I had a lot of other interests. Um,
You believe in the
Grandchildren. I like to play golf. I like to eat and drink. I love it out here in Colorado, and it was just time. And
Yeah, a friend of mine just retired, and he said, when you've had enough and have enough, that's the time to retire. And it's not an unreasonable statement.
right. And by the way, I was able to sort of insulate myself a little bit from the administrative stuff that a lot of people complain about. That really
Yeah,
wasn't my issue. I had people who did that for me, so it
yeah.
really wasn't my issue. It was time.
So, how much of the year are you spending in Colorado now?
I'm sorry. Say again. I didn't hear
How
it.
much of the year do you
Oh,
spend in
so
Colorado
we're
now?
here, I would say about 8.5, 9 months of the year, and
Oh, most of it, most of it.
most of the
Yeah,
time, but rest of the time we base ourselves out of New York. But we're
sure.
still doing a lot of traveling.
Yeah.
There's still some some of the surgical societies like to have me a couple times a year and this and that. I don't know why, but they do. I still have
Well,
some. Uh,
who are you to deny them such an honor,
and
So, any bucket list items that are on there for you to
well,
achieve?
my general goal is to play golf in every country in the world. So I'm
Yeah.
working my way through that.
How far are
That's
you?
about. I actually haven't counted, but I'm pretty far along. Um, I play in almost every place I get invited to or I travel to. I throw in around a golf somewhere along my line.
Do you bring? Are you like Ratner? You bring the clubs, or do you rent them?
Radner's been trying to emulate me from golf for a long period of time.
Um,
I
okay,
love
Barry.
it.
Listen,
Dave and I have a similar concept there.
I finished this. I finished this conversation by just a series of snappy questions, cheesy questions. They're not particularly innovative. There is no right or wrong answer to them, other than the fact that I know what the right answer is. And you don't get a chance to think about it. I just need an immediate answer, please. Are we ready to go?
I'll try.
Okay, baseball or football?
Oh, football.
Coke or Pepsi?
Coke.
Mac or PC?
Oh, Mac. Not even close. I've never owned a PC.
Cats or dogs?
I didn't hear that.
Cats or dogs?
Uh, Even.
Even,
I
ooh.
like pets.
Burger King or McDonald's?
McDonald's.
I think I know the answer to this. Beer or wine?
Wine.
Home or away?
Home.
Okay, Barry, thank you very much for your time. It's really appreciated. We will be releasing these conversations to the assembled millions who are waiting with bated breath. Um, and so,
I want to hear who else you're talking to, and I can't wait to listen to them.
yeah, well, you'll see. I've in locked in the bank right now are about 15 of them done. And I'm probably going to be releasing them maybe twice a month. They all run about an hour. I think in the little preamble I did to set up the podcast, as I point out, it's a full range from around the world. It's not just US. There is a surgeon who lives in the Midwest who started collecting cars in his first year in private practice, and he now has 83 cars,
Oh,
which
wow.
he uses for for charitable events to support his home community. I just interviewed a surgeon who he and his wife sold their house and bought a catamaran and are 2 years into their sailing journey around the world.
Talk about a bucket list item. That's great.
Yeah, yes, he said to me, I'd like to. I think we should. About when I get through the Panama Canal, let's do the interview. He said before I cross the Pacific. I said yes, let's do that. Just in case.
And I didn't even get to talk about skiing, but so that's
Yeah. So, well, I should ask you that question. How Memphis is not well known for skiing, and New York, of course, is, but it's not quite Vail or whatever. Where did that come about?
my wife had been to Aspen once when she was in University of Illinois. In fact, that's part of the reason that I met her and married her, because she was out here and she did her medial collateral ligament and then came home to mommy and daddy in a cast, and
Huh.
that's where I kind of picked her up. And I had never been skiing before in my life, and we decided we would go. Uh, After I'd met her for like 6 weeks. She said, "Let's go skiing." I said, "Sure, why not?" So we decided that we would go. She decided, she should say, that we were going to go to Aspen.
Huh.
So I told my parents we were going to Aspen together. In the meantime, we got engaged. And then all of a sudden, both her parents and my parents said, "You're not going if you're engaged. You want to go but before you're engaged, no, but you're engaged. You go if you get married." And we said, "We are going." This was 70, you know.
Yeah.
So we said, "We are going. You get us married in 3 weeks, or we're going." And guess what? My sister got us married in 3 weeks with a 250 person wedding in 3 weeks.
Wow.
Honest to God, everybody thought she was pregnant. She wasn't, but
Yeah.
and we went to Aspen on our honeymoon. So we that was in 1970, December of 70. And in make a long story short, we bought a place here in 87, a condominium, and
Yeah.
then traded it up for a house in 89, and we've been there ever since.
Mm.
So it was pretty clear we were going to retire here.
That was presumably when Aspen was achievable.
That is correct. It's totally changed. It's
Yeah.
really kind of disgusting what's happened to it.
Yeah.
It's, it's a different place now than it was back then.
Yeah. 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 But, and I mean, obviously you still ski.
Yeah.
And do you think you'll ski until you hurt yourself, or will you come to a decision, I'm not going to ski anymore?
Well, I've never hurt myself skiing. Decent skier, but I'm not crazy. I stopped jumping off mountains about 3 or 4 years ago, so I don't do that. Um, um, I think till something orthopedically happens to me, or I
Yeah.
can't do it for whatever reason. If I had a choice between golf and skiing, I would much rather play golf. But I want
Right.
to stay married too, and she likes to ski, so I ski.
I am. I'm not a skier, although I can ski, but I don't, etc. But I went to an alpine colorectal meeting a number of years ago, and everybody rushed out and went off skiing. And I thought, okay, I'll go skiing, but I'll just follow a little bit behind, these enthusiastic expert skiers. And as I say, I can ski, but I'm not a good skier. So I rented this nice young lady to bring me on the mountain, et cetera, et cetera. And we skied along, and she was Italian. And we got to the top of what looked to me like a fairly sheer cliff. And she stopped and she said, it's a little tricky. She said, what do you think? So I said to her, well, I'm not sure I'm going to be able to get down there. To which she fantastically said to me, you'll be able to get down there, all right. But it wasn't quite what I had in mind. I think she realized gravity would get me down there, all right, etc.
I mean,
Um, so I do much safer things like race old cars, etc.
I know. I'm not crazy. I realize it's inherently dangerous, but we're pretty careful about what we do. I'm
Yeah,
more worried about someone hitting me.
yeah, exactly. Yeah. All right. Well, thank you so much, Barry. It's been a distinct pleasure to talk to you, and I hope you'll join in. I'm going to let everyone know when the podcasts are going live,
Please.
and I will let you know. Okay. In the
Thanks so
meantime,
much.
stay safe and well.
Enjoy.